So our board meetings move around, and what our board has found that they used to go to these different communities, go in, have their board meeting, leave, and they never really met any of the community residents, didn't hear about any community programs. So that's, over the years, we've changed our format so that we now have, we had our board meeting this afternoon from 2 till 5. We had a board-to-board engagement session from 6 till 7, and the board-to-board engagement is where board members of the organizations in Grey-Bruce come together to talk about board issues, healthcare board issues. So we had reps from the Alzheimer Society, Grey-Bruce Health Services, from the CCAC, others.
Home and Community Support Services.
Yes, sorry, Home and Community Support Services, I should know.
Hello, John.
So that 6 to 7 time slot allows the board members to talk about issues that are common amongst the board governors with our healthcare organizations that we fund. And then this session is for the public, so it allows the opportunity for the public to come in and hear a number of presentations from programs and services that are being delivered here in your local community. And we're getting great feedback. We've done some in St. Thomas, we've done them in Ingersoll, in Woodstock, in London, and get great feedback from the members of the public that are here. So again, thank you for coming tonight. I've got a few slides that I'll go through tonight, and then I'll turn it over to our speakers. We've got a list of 5 distinguished guests here that I'll give introductions as each of them are coming to the podium. So first of all, just to get a show of hands, who's from Grey-Bruce? Who's from here at Perth? Who's from south of there? Me too. Anyone east of there? In Simcoe or? And so we got a good contingent of Grey-Bruce residents. How about board members from health service providers? Okay, providers, so people that provide care within our communities. Great. Just regular members of the community. Welcome. Glad you could come. So a good mix tonight. As I said, we've got 5 guest speakers that will go through and do a quick presentation. And then after those presentations are done, we'll have some questions and answers, where if you have questions for any of those speakers or any questions about the LIN, you can ask those questions and we'd be happy to answer them. One thing that we always stress is that please provide us with your feedback when we're done. We've tweaked these events over the last a number of months to make them better and better for the public, for board members, so please provide us with your feedback before you go. And the last thing is that we are videotaping this event, and people always say, well, why would you videotape an event like this? The biggest criticism, or one of the biggest criticisms that the LIN gets is that we don't market ourselves very well, that more people need to know about what the event is, what we do, and we found this to be a very effective means of, by videotaping, it's very quick. We post it on our website, and it actually goes on to a YouTube website where we post all the videos that we've done with our providers, with the public, with presentations from some of our health service providers. And I always tell this stat when we do these presentations. Our YouTube site last summer was the highest ranked YouTube site, not-for-profit YouTube site in Canada. Even beating some not-for-profit organizations like David Suzuki Foundation and things like that. So we've got videotapes of most presentations from our providers, from the public, from board members. So it's a useful tool if you ever want to hear something quick about some of the issues that we've done as well. So what is the South West LIN? It is a big geography. We stretch from Long Point down in the south, up to Tobermory in the north. You can see it, Elgin, Oxford, Middlesex, here in Perth, Grey-Bruce. There are some small portions of Grey County that are in the Waterloo-Wellington LIN, as well as in the Muskoka LIN. Our population is just under 1 million people, obviously a significant rural population with many small communities. Big urban population with the City of London in the south. Large proportion of seniors, so that in Grey-Bruce, I think it's got one of the highest percentage of seniors in the province. And obviously the shoreline attracts a lot of retirees from different parts of the province as well. 5 First Nations reserves, so we have 2 here in Grey-Bruce, Cape Croker and Saugeen, and then a French language services designation for those communities in the south. So we fund over 150 health service providers. That includes the 19 public hospitals. So that would be Grey-Bruce Health Services, Hanover, South Bruce Grey Health Center on 32 different sites. It also includes the big hospitals like London Health Sciences Center, St. Joseph's Healthcare. One private hospital that we fund is in the city of Woodstock. One community care access center, and we are going to hear from Kathy Kelly this afternoon from the Community Care Access Center talking about CCAC services. 62 community support service agencies, so that includes organizations like Deborah's, 28 mental health, 9 addiction vacancies, 5 community health centers. The closest community health center in this geography here is in Markdale, the one that just opened up in the old school board office. And then 76 long-term care homes, and one is still under development. So our expenditures are actually over $2.1 billion. So we provide $2.1 billion to the 150 health service providers in our area. For all 150 health service providers, we have an accountability agreement with each of them. So for the money that we provide to them, they sign an accountability agreement back to us saying what services they'll provide in return. Accountability agreements are fairly new within the healthcare system, and obviously are introducing more accountability and transparency into the services and money that flows through the system. Our budget, for our operational budget is $5 million. We have a staff of about 33 full-time equivalents. So that means that we allocate over 99.75% of all of our funding to our health service providers. Our board, and I'll introduce our board members that are here tonight. Unfortunately, some did have to take off for other commitments back at home. We do have a 9-member board. We have 1 vacancy right now. Our chair, Jeff Lowe, is from the City of London. And we've taken our the communities that they represent, or the communities where they're from, off our slide. Jeff unfortunately had to depart after our board-to-board session. But we do have Ron Bolton here. Ron is from St. Mary's. And I have to tell the story. Every time I introduce Ron, between him, his brother, and his father, they have over 50 years of experience serving on the St. Mary's Hospital Board. So, strong community commitment there. Cheryl Fagan, and Cheryl has left. Cheryl is from Goddard. She's a lawyer in Goddard. Ron Lipsett is here tonight with us, and I'm sure lots of you know Ron. Ron is from Annan, which is just outside, I guess, Meaford. Jerry Moss. Jerry is here tonight. He's from Port Elgin. Linda Stevenson, our vice chair. She actually just departed. She had a death in the family, had to travel tonight to get to Belleville. Barbara West Bartley is from Wyerton, and Barbara's up there in the corner. And Robert Wood is the last rep, and he's from the City of London, and Robert has left tonight as well. We have a staff complement of about 33 full-time equivalents, plus a few contract positions as well. So our speakers tonight, you can see the list there. I'll give an introduction of each of them as they come up to the podium. And what I'd ask is a 10-minute presentation from each of them, and then at the end we'll open it up for questions and answers if the audience has any questions or answers for the group. So Kathy Kelly. Kathy is a Regional Client Services Manager for the South West CCAC. She's worked in the CCAC sector for 11 years, in the community sector for 5, and the hospital sector for 8 years prior to that. Kathy is accountable for the South West CCAC hospital and intake case management activities in Perth, Oxford, and Grey-Bruce counties that support outstanding care every person, every day. Kathy.
How's that? Better? Okay. So just wanted to talk a little bit about who the Southwest Community Care Access Center is, and a little bit about some of the most recent programs that we have implemented over the last 5 or 6 months, and in particular some of the work that we have done with some of the system partners up in the Grey-Bruce area. So the Southwest Community Care Access Center is one of 14 CCACs across the province of Ontario. We are the local point of access to community-based healthcare, and we are fully funded by the South West LHIN. We are governed by a community volunteer board and have 7 local offices. We do have one in Warburton and one in Owen Sound, and also have small office sites in each of the hospitals that our case managers work out of. So we do connect people with the care they need to recover in the community from illness, injury, or treatment post-hospital discharge, to help live independently in the community. We do have a palliative care program to enable people to die with dignity in their home if that's their desire, and to make the transition to long-term care or other destinations. We also have programs for our children within the Southwest geography to support those children with chronic illness or disabilities. Just a few facts about the Southwest CCAC. We do provide over 2 million visits to more than 50,000 clients per year. And at any given time, we have about 15 or 16,000 clients on our caseloads. Every month, the Southwest CCAC partners to connect people with the care they need by facilitating the discharge of over 2,000 clients from hospitals to home within our Southwest area, by transitioning more than 260 clients per month to long-term care homes. We do receive more than 5,000 referrals per month for home care services. We make hundreds of referrals to community agencies such as Andy's Home and Community Support Services. And through our Care Connector program, we manage hundreds of patients every month with a primary care physician. So we often refer to those particular patients as orphan clients. And so the Care Connector program that's run out of our main office in London helps facilitate a linkage between a person without a primary care practitioner and connects them to these family physicians within family health clinics. So connecting to care system navigation. CCAC is certainly a central point of access to help Ontarians navigate to new services and settings, be it complex continuing care, assisted living, supportive housing, adult day programs, and we do provide coordinated placement service to ensure that our clients receive the best care for their needs. The case managers that connect with patients and their families apply their clinical background to thoroughly assess each individual's client needs, taking into account their medical condition, environmental and social factors, as well as their caregiver status. They continue to monitor their client outcomes throughout the care journey and regularly reassess their status and adjust their care plan when their care needs change. We are accountable for connecting clients to long-term care. The long-term care homes and the placement process in the province is regulated under the Long-Term Care Homes Act. And so the Southwest Community Care Access Center have case managers that do the assessment for eligibility for long-term care. We maintain waiting lists. We assign the placement categories for clients who are waiting for long-term care. And we help clients navigate through the complaints and appeals process if they're not satisfied with the process that they've been engaged in. So just a bit of information. Long-term care home costs are covered by the client copayment, which covers room and board in a long-term care home, as well as ministry funding that provides funds to a long-term care home to provide the medical, nursing, and personal support that the clients are provided with. Long-term care homes offer different accommodation, which is at the client's option and cost. The accommodations being basic, semi-private, and private. And those are the most up-to-date costs that those accommodation types cost. Depending on which home is the choice of accommodation, an individual could wait days, months, or years to access a long-term care home unless they accept other available choices. So in that regard, to help facilitate an understanding about entering a long-term care home and the options available for people, We do have resources available for family on healthline.ca. It's a website where clients and caregivers can access on the web and certainly navigate to the long-term care home of their choice that they're interested in. They can click on a video that has been done over the last year and posted on the helpline, and they can actually engage in a virtual tour of a long-term care home. So that's one of the initiatives that's been done over the last year. So the decision to move to long-term care is it's a very emotional decision for individuals and families, and certainly anyone that has had any loved one, parent, sibling, or other go into a long-term care home or make a decision to apply for long-term care certainly knows what I'm talking about. The client is moving home, their family, their independence, and often the decision to apply for long-term care isn't considered until the situation that the client is in is urgent. So knowing that the decision to apply for long-term care is a significant one, a new philosophy of care has been introduced in the Southwest, which is titled Home First. So Home First is a new approach to care that helps people get home from hospital as soon as possible. It empowers clients to participate in their own care and calls for collaboration and integration across the health system. The most critical piece of Home First is the idea that big decisions or life-changing decisions about where your care needs are best met are best made in the comfort of your own home. So this program launched in London at University Hospital last October, then at Victoria Hospital in December, January, and most recently at St. Thomas General Hospital. And essentially the commitment from the South West Community Care Access Centre is to ensure that a case manager connects with that client within 24 to 48 hours of their admission to hospital. The discussion certainly starts with how do we get you home versus, it's time to think about long-term care. So we're starting to, approach this paradigm shift about getting people home to where decisions are best made. So what is developed through the course of conversation with the hospital case manager and clients and family is an intensive in-home service plan, a very robust service plan, lots of services that wrap around the particular client upon transition home. It's in place for 2 to 4 weeks after hospital discharge to ensure that that client has a safe transition to home. And so the idea there then is that when people are home and stable, that's the time when they make the best decisions about where their care needs are best met. So the tentative plan for Grey-Bruce deployment for Home First is in September, November of this year. It's still, my understanding still hasn't been laid in stone yet. So, and then Burries from the Owen Sound, the hospital site, is on the steering committee. Maybe has more information about that. So under the Home First umbrella, there's been a couple of programs that I just want to briefly touch on in Grey-Bruce that have come to be over the last 6 to 9 months or so. And one of them is the Restorative Care Unit Project. And essentially this was a collaboration between the South West Community Care Access Centre, the hospital corporations in Grey-Bruce, that began in the spring and evolved over the summer until the programs were implemented at Chesley Hospital in November of 2011 and in Owen Sound in December. Again, the thinking about the restorative care was that it really is the next step in the care continuum to assist clients in returning to their former functional level after receiving treatment for an acute illness in hospital. So again, it feeds into the Home First philosophy in that these particular clients in hospital would be able to enter a restorative care unit for restoration or to return back to their former functional level versus thinking, the next step is long-term care. So again, too often decisions made to apply to long-term care after an acute care episode and based on the client's deconditioned state. So by transitioning to a restorative care unit, we really stop that piece and ensure that we get people working to achieve their goals of self-care. And so the restorative care units at Chesley and Owen Sound Hospital certainly had those interdisciplinary teams working with the clients to achieve those goals. The CCAC case manager was the single point of access for the restorative care program, in that we did the referrals and determined the eligibility for those programs. Again, it depended on terrific system partnership between the hospital sector and the CCAC, and became a very successful program. Again, reflecting on the philosophy of Home First by ensuring that every effort is made to support adequate resources being in place to support the client to ultimately go home on discharge versus another care destination. The final slide that I wanted to highlight here, again, to discuss really about the collaboration between South West CCAC, the Grey-Bruce Hospital corporations, and Andy's Home and Community Support Services, is around the Adult Day Program Transitions Project. And Andy's going to go into more detail about that. But again, it again is under the Home First umbrella, in that there was an opportunity for clients that were in hospital to access a more robust adult day care program while they were in hospital waiting for long-term care, or for those patients or clients that would be at risk of transitioning to long-term care. So while these clients were in hospital, they actually attended the adult day program, and very successfully, in many situations, we were able to transition people home versus to long-term care, continuing the attendance at the adult day program as well. So again, supporting the transition of clients from hospital to home where long-term care decisions are best made. And on that note, I'm going to look at Andy.
Thanks very much, Kathy, and we'll pass it over to Andy. Probably most of you in this room know Andy. He's been a great asset to Community Support Services here in Grey-Bruce for a number of years. Andy's worked in senior management of community support service agencies for the past 21 years. The last 12 as Executive Director of Home and Community Support Services at Grey-Bruce. Andy was born and raised in Saugeen Shores and is currently living in Owen Sound. Thank you, Andy.
I'm going to speak without a microphone, if that's okay. I just tend to wave my arms a lot. I might injure somewhere myself. So, as Michael said, I was born in Port Elgin and raised in Southampton Township. My parents retired in Southampton, so I spent a lot of my career in Toronto, but I've been back in Owen Sound for the past 13 years, working with Home and Community Support Services for the last 12 years. So I feel very fortunate to be able to work in this area where I was born and raised. Certainly I worked for larger agencies when I lived in Toronto, but there's something about working in your own community or where you were born and raised that really, when I talk about quality issues and respect and feeling responsible. When I first started with this agency, I would go around to the different adult day programs just to get to know people and see what actually happens, because adult day programs are something, it was an experience that was new to me. And I'll never forget the first time going to Southampton and just coming in. You know, two of the drivers, one of them sold me my first pair of shoes. He had a shoe store in Port Elgin in the 60s and 70s. Another one was a school teacher, and another person there was the parent of a very good friend of mine in school. So working in the community you grew up in, there's a lot of rewards besides the achievements and the monetary reward. So our organization, Home and Community Support Services of Grey-Bruce. We provide community services. They're listed below. Our transportation services. We have many volunteer drivers. We use our own vehicles to provide social transportation. We also provide transportation to medical appointments, typically taking people from their home, whether it's shopping, to the bank, to a doctor's appointment, to the hospital, to a specialist in Toronto. We make a lot of trips to Toronto and London on a weekly basis. We also have a fleet of wheelchair accessible vehicles with paid drivers that just do medical rides. And they provide rides between the medical facilities, do a lot of rides from long-term care facilities to hospital, do a lot of rides to the city to specialists or to the larger city hospitals. Our meal services, I like to say we provide Meals on Wheels from Tobermory to Teeswater, and we do. We have, I believe, 16 hot meals programs in Grey-Bruce right now. We also have a very large frozen meal program where we deliver frozen meals to individuals on a pre-arranged basis each month. Our adult day programs, we have 7 sites across Grey-Bruce counties. One in Owen Sound, one in Southampton Hospital, one in Kincardine, Meaford, Kincardine, Hanover, and Markdale. Friendly visiting program, we match volunteers with individuals who perhaps can't come to an adult day program because they don't do well in a group setting, or perhaps they just don't want to come. There could be different reasons. So we match individuals, volunteers, who will go to their home on a weekly basis. We have a very large housekeeping home health service where we send paid homemakers into people's homes on a pre-arranged basis. This is the top of the breakdown of client age. This was just a slide from a presentation I did a couple of years ago. But this is a slide that always strikes me as very telling because this is just one of the programs we deliver. And if you look at the top is the breakdown of ages, and then the numbers across the bottom are the number of clients under those age groups. So when you look at the 80 to 84 age group, certainly that is by far the largest demographic that we serve. And I would say that's typical of most of our programs, perhaps with the exception of transportation, where we may say serve a somewhat younger population. Our organization has 91 employees, 1,200 volunteers. We're very proud of that. And we serve about 4,000 individuals on an annual basis. This is the level of service we delivered last year. So 52,000, almost 53,000 meals. 632 meals served at a dining club that operates out of Walkerton and Maple Court Villa. We provided almost 36,000 trips. Most of those would be for medical transportation. We provided 1,369 visits, 14,500 hours of homemaking, almost 11,000 days of day away. And the caregiver supports, we have staff in our adult day programs. So those are documented contacts between our adult day program staff and caregivers of people who attend the adult day programs. So that's a significant number. So that's actually outside of the delivery of the adult day program service. That's people contacting our staff, contacting typically family members of our clientele that attend the adult day program. Our funding comes through the South West Local Health Integration Network and user fees. We have user fees for Meals on Wheels, adult day program, homemaking, and transportation. We divided Grey-Bruce County into 5 areas just for our own administrative purposes. As everyone knows that's from here, Grey-Bruce is a very, very large piece of geography. So we divided it into 5 areas just so we don't have staff spending as much time in the cars. If you're going from Southampton to Tobermory to see an individual, that can pretty much kill your whole day. So we actually have independent staffing teams in each one of the 5 geographic areas. And I think the next slide will show a map of how we divided Grey-Bruce County up. It's partially done on population, but also certain areas naturally flow into others in Grey-Bruce counties. Port Elgin, Southampton, for instance, typically flow. Hanover and Walker typically don't. The Grey-Bruce County divide. I'm going to talk mainly about our adult day program. People might be familiar with Day Away. That's the friendly term that our volunteers, our staff, participants, their family members always call the Day Away program. The Day Away has evolved a lot, certainly since the time I've been with the agency, but particularly in the last few years, who we see coming to the adult day program has changed. And the slide that showed the breakdown of people's ages in one of our programs, it's very telling because Many people are being diagnosed earlier in the disease process. So we're seeing younger people with an Alzheimer type dementia, and we're also seeing people coming to us who are much frailer and sicker. So sort of the point where the caregiver is really struggling to cope and are pretty much in crisis by the time they come to us. So we're seeing both ends of that spectrum. I like to refer, I've got a description up here, but I like to refer to DAOA as sort of a three-legged stool. There's a social recreation aspect to it where we have individual plans for each individual who attends. We try to stimulate them to the best of their own ability, do things that are interesting for the individual. We also have a nurse assigned to each one of our adult day programs. So there's a medical monitoring aspect where they do weights and blood pressures, they monitor medications, and typically the nurse is the liaison with the family physician or the family health team. And social rec, the medical monitoring, and the nutrition also. We provide a very balanced meal and snacks throughout the day. And the caregiver relief aspect, certainly it provides 7 to 8 hours of relief for the caregiver home. We actually go out and pick the client up and take them home at the end of the day, so the caregiver is not going to bring their loved one into the program. This is where our adult day program sites are located within Grey-Bruce counties. I'm sure most people are familiar with all of those locations. As you can see, with the exception of Kincardine, we're perhaps all located within other healthcare facilities in Grey-Bruce counties. This is a new program we began in December. As I said at the beginning of my presentation, things are changing very rapidly in community healthcare, and we're changing things to try and meet the needs of the individuals that we see in the community today. And this is an example of a program that was really put together very last minute, but I think it really meets a need. And as Kathy mentioned, we work very closely with the lady with the hospital, with Kathy, the CCAC, to get this program up and going, and to evolve the program and try to better meet the needs of individuals. So we're taking people directly out of hospitals, people who are in an alternative level of care bed. So what that means is usually come into the hospital through acute care, and they're waiting often for long-term care placement. The caregiver at home perhaps just cannot cope any longer. The person is coming because they're ill, and the caregiver at home just says, I just don't know if I'm in a position to take this person back home. So what we want to do is get that person out of the hospital as soon as possible, into a social recreation experience, and improve their health care, and then get them back home with the caregiver knowing that they're going to get that break or several breaks through the week where the person's gone 7 or 8 hours a day. And in some cases, some of the individuals have come up to 5 days a week, so it does provide significant break for the person at home. They would have to attend different adult day program sites to actually be able to attend 5 days, but that has happened. All referrals are made to the CCAC case managers assigned to the hospitals. And one of the positive things we found about this program is how quickly people transition into our regular adult day programs. There was certainly some trepidation on the part of our staff in the adult day programs, taking people directly out of hospital. It's not where our clientele typically come from. There were some worries about escalating behaviors, functioning in a group setting. And we found that the behaviors of almost without exception, everyone coming out of the ALC in hospital, and we were dealing with more behaviors and people with more physical challenges in our adult day programs already. So that was certainly a learning experience for the staff in the program. This just tells you a little bit more about the program. It's actually, I would still consider it a pilot. It has been funding for the coming year, which is April 1st, 2012, March 31st, 2013. This is also being piloted at the St. John's Adult Day Program, not St. John's, Salvation Army in London. And we worked very closely with them. That's been a great experience. developing policy, communication, frameworks, and just problem solving some of the issues. And there are a number of issues within healthcare around moving people from one system to another or one provider to another and moving the information with them. So it's been a real learning experience and a positive experience working more closely with the hospital and Community Care Access Center. This is a program that's going to start in the next month or two. This also fell in the Strata Village learning. We found a number of our caregivers with individuals at home, their loved ones attend the adult day program, and we're getting to the point where even with that relief through the daytime, they become overwhelmed because a lot of people with that Pepper's disease process, they kind of wander at night. The caregiver often can be sleep deprived, or they just need a break of more than 8 hours. So this is something we're going to try. We're still in the planning process, but we are going to begin this, I believe, April 13th in Hanover, and then we will start on June 13th in Wyerton at our adult day program sites. So people will actually be able to come to the day away program per clients and spend the night. So they'll come for the day, spend the night, and then perhaps spend the next day at the adult day program. So it provides that extended break for the caregiver at home. This is something totally new for our organization. We've never provided an overnight service. We're working through a number of the challenges right now, but we're very confident that we will, if we don't make our April target in Hanover, May, we will be operating by mid-May. And that's it.
Andy, maybe I'll just ask you a question while you're on the stand here. Those programs that came so quickly, I guess, can your agency accommodate that quick uptake? And is it worthwhile for us to make these quick investments and get the uptake so that clients are better served?
Yeah, that is a good question. It certainly challenges us to come together as a team, our staff, but there is a lot of support. And as I said, we work very closely with the Community Care Access Center, with the Lane Hospital, but the Lynn also, Julie Gerard from the South West Lynn. We're at a home conference every Friday, sometimes twice a week. It's a significant commitment from everyone involved, and we can do it as we've proven. 5 or 6 doses a year. Might be a little bit much, but there's a lot of excitement around these new programs, particularly the overnight program. We've seen individuals, some of these individuals come to our programs for a very long period of time. And we see them through the disease process. And our staff become very, very attached to these individuals. And when it gets to the point where the caregiver is breaking down at home, and the individual, they're looking for other options just to be able to keep going. When we get onto that, we all feel better, so it's well worth the effort.
Great. Thanks, Andy. Thanks very much. You can see from the slide that our next speaker is Deborah Barker from the Alzheimer Society of Grey-Bruce, and I'll just give a brief introduction to Deborah. She is the executive director and has been for the last 17 years. She's a registered social worker, and she represents the society in a variety of community groups and has a leadership role as the co-chair of the Behavioral Support Services Geriatric Cooperative and as the treasurer of Grey-Bruce Geriatric Education Cooperative. Deborah is on the steering committee for the Grey-Bruce Integrated Health Coalition, representing the community support sector. So welcome, Deborah.
Thank you. Can you hear me? Is that on? Yes. Good? Okay, thank you. So in January of 2011, the Alzheimer Society of Canada released a study called the Rising Tide Study. And this was a national study done to look at the impact of dementia on Canadian society. There's been some excellent response to this, and just to highlight to you some of the numbers from that response. from that report, rather. The challenge that we're facing in Canada right now with the numbers of people affected by Alzheimer's disease and related dementias is that right now we have over 500,000 Canadians living with this. Within a generation, we'll be looking at over 1.1 million Canadians. The cost to Canadians for dementia care is currently looking at $15 billion. Within a generation, $153 billion. The time Canadians will be providing informal care, so this is not the hands-on professional care providers, but family members, friends, whatnot. We're now looking at 231 million hours of care provided. Within a generation, 756 million hours of care. We have a significant change happening in our healthcare system, and we are definitely going to see the impact within the next few years. At the Alzheimer Society of Grey-Bruce, we are definitely seeing the impact now. The numbers of clients that we are seeing over the last couple of years has definitely grown as people with dementia, generally your likelihood of developing the disease increases with age, and with our aging population, our client flow grows. So First Link is the program. We actually were piloted this project, started in 2007, so we've been running the program in our chapter for a few years now. We are funded by the LIN for First Link. We get about 60% of our funding for our organization is from the LIN. The remainder of our funds we do fundraise through special projects and events in the community. So First Link is trying to address those numbers that I presented to you. We need to change the picture in terms of how we're going to respond to the growing number of people affected by Alzheimer's disease. The Rising Tide report talked about the importance of delaying the onset of Alzheimer's disease, and the recommendation, of course, is a healthier lifestyle. So we want to see increased physical activity, we want to see a healthy diet and a healthy lifestyle. This will delay the onset. And First Link, a component of that is promoting brain health to the public. So that's one component of the work that we're doing. Changing the picture will also require skill building and support for informal caregivers and people with dementia. And this is a big piece of the First Link program. So First Link provides education and support for the persons diagnosed with dementia, as well as for their family members. We also, of course, provide support for the professional caregivers as well. And another recommendation of the Rising Tide study was that a system navigator for newly diagnosed patients will help provide care coordination. And system navigation is a big piece of the work that our counseling staff does through the First Link program. We connect them to appropriate community support services so that people can stay at home longer or be cared for outside of the healthcare system. So First Link is basically working together to link individuals and families affected by Alzheimer's disease and related dementias to a community of learning, services, and support. Very simple slide, but it shows the Alzheimer Society basically has three arms. We have our First Link services. So any client who comes into our organization is a First Link client. On the left side, we talk about the professional education. It's primarily our public education coordinator, Sandra Long, who takes on this role. There's a few little acronyms in there, but the pieces, You First, and Gentle Persuasive Approach training are standard training sessions that we provide for healthcare providers in the community. We do case-based learning, so if the care providers are having challenges with how to provide the best care for a particular client, our staff will go into the long-term care home and do an assessment of the client, spend some time with them, and then make recommendations for care on an ongoing basis. On the other side is a new position we have through the Behavioral Supports Ontario. We have a part-time social worker who you'll be hearing more about this program when Leah gets up and speaks. Just locally, looking at Alzheimer's disease and related dementia statistics in Grey-Bruce, Dr. Hopkins out of Kingston does projections county by county for Ontario. In Grey County, in 2012, just under 2,000 people over the age of 65 diagnosed with dementia, and in Bruce County, just over 1,200. We know that that number is lower than reality, because of course there are many people under the age of 65 who have dementia. There are many people who are not yet diagnosed. So that also as well does not include the caregivers of those affected by this disease. So we know that the numbers actually are significantly higher. Just some very simple statistics for you, showing you how things are changing as our First Link program is growing. So comparing the fourth quarter, so the end of last year, number of caregivers served was 547. So at the end of Q3, which is December 30th, we had 609 caregivers. So, we still had 3 more months to go, and we were obviously over in the number of caregivers. Number of self-referrals, you can see the same kind of growth is happening. Persons with dementia, obviously we definitely have grown in terms of connecting with people with dementia. We're basically at the same number at the end of 3 months as we were at the end of 9 months as we were at the end of 12 months last year. That is primarily because of the work that we're doing, partnering with the family health teams across the 2 counties who operate memory clinics where there's cognitive testing done, and our staff are there with the family health teams doing those assessments with the persons with dementia and with the caregivers. And our professional referrals are definitely increasing, again, as a result primarily because of the memory clinic work that we're doing, but also I think we have improved partnerships with the CCAC, with other organizations, and we're getting more referrals from other professionals. So basically, First Link is 3 areas that we're doing work in. So education, we have our First Link learning series, and we actually have 5 different series that we offer to people, basically depending on the stages of the disease that the person is at. We have a first step session for the person with dementia and their caregiver. Very powerful group for people to participate in, to come into a room. You've been newly diagnosed with dementia, and you come into a room and there's other people that are sharing the same experience. You are very important and reassuring for those members. So that's one of the sessions. We have a session on care essentials. We have a session on planning for the later stages, moving into long-term care facilities. So that First Link learning series we're offering throughout Grey-Bruce and trying to cover the whole geography of the area on a regular basis. And that's been a challenge because our staffing is limited and we have a huge geography, and we want to be able to, at the point that someone is diagnosed, be able to say, we have a First Link learning series that you should attend. We don't want them to have to wait 6 months for that learning series. So we're trying to work the best way to make that learning series available. Dementia 101 is a new service that we're offering as a way of providing follow-up to people. Because our numbers are growing so significantly, we only have 3 full-time and 1 part-time counseling staff. And at this point in the calendar year this year, we've had over 1,000 referrals. So for those counseling staff to follow up with those over 1,000 clients, is becoming more and more challenging. So we're going to be trying, we've just been doing the training this week with volunteers to call some of those people who are slated for follow-up and offer them the opportunity to attend a Dementia 101 group meeting as a way of trying to connect with them and provide that ongoing support and follow-up. We, of course, our counseling staff do individual mentoring, and then, of course, the education for professional service providers. Support through our caregiver support groups. We offer groups in 7 different communities, 8 different locations. Some morning, we do have an evening group in Port Elgin. We have early stage support groups. Again, very, very powerful groups for the people who are members of this. What we found with the early stage groups is they're generally time limited, 6 to 8 weeks, because people progress through the disease and it becomes more challenging for them to participate in an early early stage group where they talk about the challenges that they're experiencing day to day. So the early stage groups are very important and very much appreciated. Our problem is that people don't want them to end. They want to keep going, and we don't have the staff to keep them going. We most recently transitioned a group into an art therapy student program, and that was very well received. And of course, we do the individual counseling. I mentioned that we do the help of navigating through the healthcare system, and of course, the referrals to community services. Certainly our targeted outcomes, you'll probably hear this from all of the healthcare providers, is prevention of caregiver burnout. That's a main goal. We want to be able to support caregivers to keep the person at home for as long as possible. We want to delay that long-term care placement and reduce preventable ALC and emergency department usage. In order to do that, we of course depend significantly on a number of partnerships. Behavioral support, you'll hear about from Leah. I talked about our work with the memory clinics where we make those connections with people at the point of diagnosis, and that's so much different than 17 years ago when I started. It was always people calling in crisis. Things are terrible, I have to put mom in a nursing home. Now we're there at the point of diagnosis, and the picture looks quite different. We work with the geriatric resource team with the Community Care Access Center, again, which is part of an assessment process. The case managers, our counseling staff will actually go and do home visits and assessments with the case managers from the CCAC, and that has proved very worthwhile. Closing the Gap, of course, provides the occupational therapy and physiotherapy, so our staff are very much in touch with them. Of course, we are connected very closely with Home and Community Support Services, referring back and forth. The Geriatric Education Cooperative is a group that provides education and training for frontline staff for geriatric patients, and we work very closely with that group. Grey-Bruce Health Services has, the Owen Sound site is doing a delirium project, and we've actually our connection with the Geriatric Education Cooperative and the delirium project, because many people present in the emergency department with a delirium and often need a referral to the Alzheimer Society. Just a couple more slides. Just wanted to mention some of the gaps in services that we've identified. We do have, through First Link, the potential to address some emergency department usage and help people with dementia to live longer at home. However, in order to do that, families do need respite and transportation to attend the First Link education and support series, and that is the challenge, is getting them the respite so that, have a PSW or whatever come in to stay with the patient or the client at home while the caregiver goes to the group. The other challenge we've identified is that hospital emergency departments need to identify and refer to First Link any clients who have dementia and the family caregivers who need the help to put in plans in place so that there will be some avoidable, to reduce avoidable ER visits. We do have some capacity issues, as I mentioned. Our services have expanded with limited resources because we're trying to meet the need. We have 5 new monthly early stage education and support groups, 4 new monthly dementia one-on-one learning events, and 8 learning series offered between April and October of this year. So we have a very ambitious schedule that we're trying to fill in order to meet the need. We're now supporting 8 memory clinic sites with on-site support. That number is growing to 10. It's actually 14 clinics that are held each month. And almost every patient seen at those clinics is a referral to the Alzheimer Society. So we do have a growing number of cases, which is making it very difficult for the follow-up calls, and that's why we're looking at the group follow-up for people who could be handled in that way through the Dementia 101. So just to finish off in terms of some of the successes today, we're very proud of our work with the memory clinics, because what's happening at those clinics is a very seamless First Link referral. The patient is getting diagnosed with dementia, and the physician is, if we weren't there, would be saying, call the Alzheimer Society, and we know they wouldn't. But because our counseling staff are there, they make that connection and they take the support immediately, and it's making a big difference. We have still been able to meet the standard of initiating first contact with a client within 4 weeks of referral, and that's our provincial standard to do, and we're still able to do that. We are, as I said earlier, diagnosis and treatment means we're now seeing clients sooner after the diagnosis. And the last one, we're directly connecting with 13% of those in our catchment area who are living with dementia. That is the highest percentage of any Alzheimer Society in the province, so it's good. There's 87% though that we're not reaching. We just did a press release on Monday, it was in the Sun-Times, and had a woman walk in the office and say, I'm 1 year 87%. So that was great. It's, I think the First Link program is having some success in terms of making connections with people and getting them connected with services that can keep them at home longer and supported and cared for at home.
Thanks very much, Deborah. And it's clear that partnerships are a key theme in the presentation tonight. Our next speaker is Leah Wood. Leah is the co-director for Mental Health Services with Grey-Bruce Health Services and has been an employee there for almost 40 years. Her entire career has been in the mental health field, covering geriatrics, acute short-stay and group therapies, until moving to management 20 years ago. Welcome, Leah.
Thank you for inviting me and allowing me to speak to you tonight. I'm going to take a card from Andy and do away with the microphone. If anyone can hear me, just please speak. Okay, I'll speak up. So I'm here representing the newest program that has come to the mental health portfolio, and that's developing a behavioral support system for adults with responsive behaviors. And our funding comes from the South West LINs. And we would say that all behaviors have meaning. So that's what we address. And behavioral support systems for older adults, and we address the responsive behavior section. And we were formed as a part of the Aging at Home strategy, and now we've dovetailed with the Behavioral Supports of Ontario project. Our overall aim is to improve the quality of life for older adults with responsive behaviors. And this might be, and those responsive behaviors might be due to mental health issues, addictions, and dementias related to neurological conditions. Now, I would say to you here that we, at this time, we are not addressing patients or clients with acquired brain injury or developmental delays. So at this time, at least. Also, our aim is to enhance the existing geriatric mental health services available in each community and build on existing resources. So partnerships, as you've been hearing, is a big part of linking up and doing the enhancements. Mental health services, I would say, prior to this project, didn't do very well serving geriatric outside of our hospital, at least in the mental health sector. We would see them when they arrived in our door and we would service them, but we didn't do a very good job of going out into the community. The clients may exhibit responsive behaviors or challenging behaviors, and they might present themselves as a form of aggression, resistiveness to personal cares or taking medications, and you would see wandering behaviors and a general sense of agitation within the client. And these behaviors are a major distress, not only to the person exhibiting the behavior, but certainly to the care providers and to the family members. Also to people, if the client was living in a long-term home facility, then the other people living within that might be distressed by the behavior as well. So you can see that the impact goes well beyond the person himself. The geriatric, we refer to them as the BSS team, provides service and will go to wherever the client is that needs that service. So whether it's in a long-term care facility, to a person's home, and any community setting. So a lodge, we might be called to a lodge and provide service there. And we will go with it. Team members are highly skilled. We have a medical background, but on top of that, we have additional skills in mental health and addictions, and we have strategies for effective management of responsive behaviors. Team members, presently we have, approximately 7 people on our team, and they have a very good understanding of the community services and resources, and work in partnership with all of the agencies, many of who are present here today. One of the coming together that we did was form a geriatric cooperative. And one of the very first things that we learned was the services each of us provide. And so while I thought I knew a lot of the services, it wasn't until we started working together in the cooperative that I realized that there was a lot about the service I didn't know. And so I think one of the learnings that I've had is that while everybody will tell you their mandate, then they go on to tell you how they stretch the boundaries. Given that we're a rural area and services are somewhat limited compared to an urban area, we tend to stretch those boundaries of the mandate outward to try and service people as best we can. So one of the other things that we've learned is not to overlap. We don't have enough resources to overlap, and so sometimes it was hard to distinguish where one service left off and the next one began. And so even within ourselves, we will be making referrals. So this slide here demonstrates that the long-term care community will make referrals. We will come into a centralized intake on our team, and it will be triaged as to whether it's appropriate referral to us or not. I think we're a little negligent in not adding in one more box. It doesn't end there. If it wasn't an appropriate referral to our service, then we would make that connection, and that's the benefit of working in the cooperative. So we would make that connection for the referring service or the person. If they are eligible for service, then we would do the intake, we would review the process, and we make a contact within 2 hours. That's the standard set. And then we would reach out to the referral service of the client and make an appointment either on-site through a telephone consultation called OTN, which is the Ontario Television Network. And we use that as a medium. And we would reach out to make an appointment and start gathering the information to get out there and make an assessment. One of the goals that we have, and I was remiss on not putting it on the sheet, was knowledge transfer. One of our goals, we go to assess the client, and that's our main objective. One of the byproducts of that, and it's very positive, is the transference of knowledge. So while we're out there, we work with the staff who are the family caregivers and transfer the knowledge from the person doing the assessment onto the caregiver and or the staff, and make them, feel a bit more confident, build capacity within the system. And so the next time they run into that situation, they feel a lot more confident to be able to handle it and pass that along to their colleagues as well. So building capacity is a big piece of what we would be aiming to do. So thank you. Any questions?
You've got the process there, but what is your eligibility criteria? How does someone fit your service versus some CBCD or just staying within the home?
Well, that's a good question, because that's what we had to learn in the geriatric cooperative. So it's responsive behavior that would be the key. So CCAC had a founding team of geriatric resource team, and So they'll go and do assessments as well. They may actually be the referring source to us. So if the responsive behavior is more than they have time to deal with or can deal with, they would refer to us. Likewise, when it says inappropriate referral, if someone self-referred to us, and when we did the intake, found out that, well, perhaps that isn't the degree of service they need at this time, we would then make the contact back to CCAC or whoever, so we refer back and forth.
So it's all dependent on the behaviors that are.
It is the behaviors, the behavioral responses is what would generate the activity to go over more. And I'm sorry, yes?
So are you associated with the Grey-Bruce Health Services in Sound? Is that where you're located?
That's where this team is located. This would be, we have 16 mental health programs, and this is the newest program, and it will make our 17th program. Yes, and so we are housed in the Owen Sound office, but we have satellite offices throughout, so people would have maybe an office in a long-term care facility, and would be based out of there as well.
So just as an example, if I happen to know of an elderly person who lived in very ramshackle circumstances, who was behaving in strange ways, and he didn't have any family, and I knew that he had, as you call, responsive behaviors, and was not knowing that he had a physician, could I, as a neighbor, refer this person to you?
People can self-refer. Yes, we'll take the call.
But if this person would, like if this person, let's say, is not capable of doing that,
Yes.
I could, as a neighbor or someone who knew him.
We'll take that information and we'll go out and we'll see what, either make a connection ourselves or see that someone else is out there making a connection. We have Dr. Mulroy is our supporting physician. So we meet with him and go through the client list once a week. And so in the sense that we need a physician to work with us. So most appropriately, the referral would have a physician in the background, because we would see the patient. What we would do is assess and make recommendations. So we really need either a nurse practitioner or family physician to work with us in order to achieve the goals for the patient. But yeah, there's vehicles for that. Thank you.
Great, thank you very much, Leah. Our final speaker tonight, normally when we do our public engagement sessions, we always have a patient or a client come and give the patient or client experience. Tonight we actually have a caregiver. So Michael Graham is here, and he's going to come and talk to us about the caregiver support that he's been providing to his father, and his mother Patty is here as well. So welcome to both of you, and if you're pleased to be here tonight to talk about your experiences.
Check. Okay. My name is Mike Graham. My mother, Patty. Fortunately, I woke up this morning with the flu, so I'm going to try and get through this as soon as possible. So I guess I'll start with a little introduction of who we are and how we relate to the community. My mom here, she's from Kincardine, born and raised. She's moved up to Wyerton and built our life there 30 years ago. Her and my dad, who we'll be talking about today, they started there about 30 years ago. I was born in Owen Sound, went to high school in Wyerton. I live in Salt Beach now, but I work all over the area here. Just moved up from London, actually. Just the back and forth was getting a little bit too much, so back in the area full time. So anyhow, I guess where I'd like to start, I plan to start with an idea of what's going on with us and our family is our dad. He's an Alzheimer's patient. We've used several of the services that we discussed tonight, and experience has been phenomenal. So let me give a little background on Dad there. We have to go back to 2004. April of that year, I was 23. My brother, 21, and my sister, just 19. Graduated in June from Conestoga College, and that same June, Dad got diagnosed with early onset Alzheimer's. So as you can imagine, it was quite a shock to the family, especially small business people that my parents were. They were, my dad was a welding contractor. He built, very smart guy. He built just about anything with his bare hands. He worked at commercial alcohols, built several huge additions for that plant down there for 11 years. So yeah, it's no mental illness in our family whatsoever. Just a complete lottery that he got this, and we didn't know what we were going to do, to say the very least. So I deal more closely with the day-away. I want to talk a little bit more about the day-away side of things, as I've been closely connected with the day-away people, just through my schedule permits, the dropping off and picking up, and hanging out and stuff with them. I like to participate sometimes too. So Mom here is going to talk about the Alzheimer Society and CCAC as well. So we'd be happy to answer any questions when we're finished here too. So if anybody has any questions, then we're happy to help. So just pass the mic over to Mom.
Well, can you hear me okay? All right. Yeah, as Michael was saying, it was quite a shock. Kids were all away at school and that, and my husband was having a bit of difficulty, and so we went for testing and everything, and we thought, okay, well, it's depression, he'll get over it, So after all the tests and that, then eventually the doctor sat down with us, and he says, I'm sorry to tell you, your husband's got early onset Alzheimer's. The news was devastating. For a while you go into shock, you don't believe it, and you go for a couple of years trying to handle everything yourself, which was really hard. And then, like I said, I held it even back from the kids for the first couple of years, and that, they could see some changes, but eventually, I told them, what was going on. And, my nurse practitioner, eventually she said, you got to talk to somebody, so she's the one who put me in touch with the Alzheimer Society. And I went there and I saw a counselor, and they've been really good. They give you support that you need, and they actually got us in touch with CCAC, who has been wonderful as well. Now, I've been getting the newsletters from the Alzheimer Society. I've been to a couple of caregiver groups. We participated in one of the first memory clinics. Now, with that, they were eventually the ones that took my husband's license from them, so he wasn't too impressed there. But we were getting to the point where we didn't know what to do, and that. So they did the testing and the diagnosis, and they said, I'm sorry, but you can't drive anymore, which was devastating for him, but we coped, And yeah, it's just, I didn't know all these support services were out there, but they've been really, really helpful. And we've used, like I say, a number of the services and that, and it's been an ongoing journey. My husband's gotten much worse, and like I say, it's been an ongoing journey, and it hasn't ended yet, so I'm sure we'll be using a lot more of the services yet. It's good to know they're out there and that we have the support and that. And my husband, he does go to day away twice a week in Southampton here, and he wasn't too sure about it in the beginning, because I don't know, anybody that knows Alzheimer patients know they get anxious in a group and that, and he wasn't too impressed at first. He was sort of on edge and everything, but after the first couple of times, he's made a lot of good friends there, and he loves the girls. They're terrific. he'd go every day if you let him, you know, it's been wonderful. And also through CCAC, I have a home care worker that comes in on Wednesdays, which allows me to go to work, and I don't have to worry, you know, and that, so, because he can't stay at home. And so that's been a help between them and the family here, my kids, you know. But like I say, it's an ongoing journey, and I'm sure things are going to get worse. So, you know, we will probably continue to use the services and probably more of the services. So, anyway.
Yeah, I guess I don't have too much to add to that. I started when Andy called me there last week to come down and say a few things. I started to, you know, trying to think of what to say and formally write something. But I think after about 4 pages, I'm just like, this is never going to work. There's just too many good things to say about the people and the programs. And it's funny because they thank me and us for coming down to talk, but I mean, it's the least we can do to pay it back, you know. And yeah, there's just nothing bad about them. And the more services up here, the better. And going by the stats that we see tonight, we're going to need them. So, yeah, I guess that's it for the rest of the night. If you have any questions, we're happy to answer. So.
Any questions for Michael or Patty?
Don't be shy.
I'm curious to know whether
Sure.
your family would be able to participate in the overnight program that's going to be operating out of Wyerton. Is that something that you think might be helpful for the family?
Oh yeah. I think that something like yes and no. I guess it all depends on I guess where he's at with the illness and yeah. I don't know. I think it's very good.
Yeah.
I'm sure it would.
Yeah, I don't know. It depends on where he is at. Like I say, it's anything that's unfamiliar, he feels uncomfortable with. Daily, he really enjoys. An overnight, people yes and no, I don't know. Maybe in time. It depends on how the disease goes and where it goes. You know.
My question is, where are the memory clinics? Where do you keep going for that?
In Owen Sound.
And are they around all of Grey-Bruce too, or do you have to go to Owen Sound?
I don't know. Owen Sound was the one that we went to. And we actually got in on the initial, I think, the first day that they have it. And that, so I'm not sure if they have any more clinics or not. Probably a nice doctor would find out and recommend that, or maybe do the Owen Sound Hospital. I know we went through our next practitioner.
I can speak to that. The Owen Sound Family Health Team and the Brockton Family Health Team are doing family clinics. Dr. Monroy of GBHS Mental Health Services also does them at 6 different hospital sites.
So Walkerton and Owen Sound?
Yes, and I think that Mildmay and Paisley may be coming on. Hanover also has a family clinic.
Wow, this is, I think, the main reason why all of us are work in healthcare and are associated with healthcare because of experiences like this. So thank you very much, Patty and Michael, for opening up, sharing personal experiences, showing your appreciation for the programs and services that exist here in Grey-Bruce. It's a real great way to end our evening tonight. So very much appreciated. Thank you very much. Any further questions before we wrap up? Yes.
I admire all the programs that are available to all these people. My question is there enough funding to have enough RNs, RPNs, PSWs in the program to be into the community at all times? There isn't enough now. With all these added programs, are we going to be short of money to train them or to allow them into the homes?
I'm not sure, Andy or Deborah, you want to try and talk that, and I can speak from the link perspective as well, or CCAC?
Yeah, from our perspective, we currently have capacity. There's been resources, financial resources, put into our community services over the last 6 months particularly, but over the last 2 years, we've been more than in the past, perhaps. So our issues are more around, our issues are more around the time lapse of recruiting people, finding qualified staff, particularly staff that work in the community, because you have to drive, obviously. Yeah, we're in a position where we are accepting people. We'll be serving more people in the future, and we're just sort of building to that because, as I mentioned during my presentation, a lot of our funding is some of our funding is very recent, so we're just really gearing up process to serve more individuals. But I mean, when you look at the other statistics, I mean, whether everything enough, I don't know.
Well, I guess just a comment in terms of the education, that is a big challenge. Our staff did, in partnership with the CCAC and Grey-Bruce Health Services over the past 4 or 5 years, training in the gentle persuasive approach in every long-term care facility in Grey-Bruce. But we just heard statistics today that at one time we had staff in every long-term care facility trained in this program. Today we heard, I think it's 2%. So what's happening is those staff, I think, have retired or else they've moved into the hospital settings because I think they get more pay in the hospital than they do in the community. So there's just a transition there and it's having an impact on that. So we have our work cut out for us to keep the staff trained in the long-term care facilities in the community.
I guess my question is there enough money coming from within to train these people?
So I guess another component of this is that funding is shifting from acute care into community. And you can see it consistently in the last number of years coming from the provincial government. You can see in the provincial budget that was released yesterday. Funding increases for hospitals are lower now than what funding increases are from community organizations. So it's a fundamental shift in terms of where the resources are now going. And you'll hear from the Minister of Health, this is a consistent message that she delivers, is that she wants to make sure that there are enough resources in community to provide the services that are required. I think, as Andy indicated, there's always an appetite for more and more service. So the debate of whether there's enough money coming into the system, the shift is moving in that direction, but there's always an appetite for more. Yes.
For your website, for the LIN, are the organizations in Grey-Bruce connected directly to that? So you go through the LIN, these are all of the speakers, well, except for the 4 speakers today, are they directly connected?
Yeah, so you can, what I'd encourage you to use is the helpline.ca. So the helpline.ca is a website that's run through the Community Care Access Center, and it lists every organization that's funded by the LIN, as well as other organizations that are connected to healthcare services. They list contact information, websites, all that information is there. So it's called thehelpline.ca, and all the information for our speakers today will be there.
All right, thank you.
Yes?
Would you speak to the amount of respite care that's offered in Grey-Bruce counties for people like Mike and Patty?
In terms of dollars?
No, facility.
I don't know if I can answer your question for you. I'm not sure anyone else that was on the blue card as the speakers can assist.
If I may, I think in Grey-Bruce there used to be a number of beds that were designated as respite beds. This is old news. And I think because there was not the return, because they're not always filled, that many of the hospitals were allowed to just get rid of them. So that, and I'm not sure of the numbers now, I think it's minimal, that there are places where somebody can put a loved one while they go away or sleep for 3 days. And I think the question might be, what are those resources now? Or
Okay,
you
so
might-
I don't think I can help you, but Elaine, maybe just introduce yourself as well.
Sure, I'm Elaine Burns, and I'm Senior Director for Clinical Services at Grey-Bruce Health Services. I'm commonly referred to as Elaine when everybody says they collaborate. So, a lot of retirement homes, lodges, et cetera, provide respite care, and my understanding, and I can't speak for the whole of Grey-Bruce, but for those places that I know, that those rooms are booked on a regular basis. Hospitals providing respite care is something that went away a long time ago, and I've been around hospitals a long time, so I can give you that historically, because hospitals are about acute care, and respite care is not acute care. A lot of long-term care facilities also provide respite care.
No.
I think there's only 2 beds.
I think you're right there.
Two beds in all of Grey-Bruce, one for women and one for men.
In long-term care.
Yes, like this one. My husband has passed away, having had Alzheimer's for 7 years. There was no bed in Grey-Bruce County for him for respite.
Well, I'm from the Meaford area, and I know that several of our
They would not take him. There's only 2 beds in all of Grey-Bruce County for respite care for a person that's looking after an Alzheimer's patient.
Okay, so in terms of dealing with the behaviors.
Yes,
Okay, I
yes,
see
2
what you're
beds.
saying. Okay.
And let me tell you, I took my husband to Southampton Care Center, and they called the police, and he was put in the psychiatric ward in Owen Sound.
So a lot of long-term care historically has not had the ability, and that's what Deborah's working so diligently with them, to understand responsive behaviors and how to handle that. So that would be why it's often difficult to get somebody placed into a long-term care facility if they have behaviors.
But the interesting thing is, as a caregiver for an Alzheimer patient, I'm allowed 90 days in a year for respite. No place in Grey-Bruce would take my husband. So I said to CCAC, and good for them, you need to find me a place where I can take my husband. So they found me this wonderful facility in Simcoe County. And my question is, why can they have it in Simcoe County and we can't have anything here in Grey-Bruce?
So it's a very good question. Leah, do you have anything else to add in terms of services that you could provide?
Right, now we wouldn't have any respite beds. We used to, as Elaine said, on psychogeriatrics, commonly known at one point as 8-4. We did operate 2 respite beds at no cost to the public. Then what I would say is that those beds were moved out to the community, and that was a decision that was made. And I know in the peninsula, Golden Dawn had 2 beds. Now, the question is whether in fact they would then take clients with behavioral, or whether it was more medically based. It sounds to me from what you're saying that they went more medically based for respite. I would say, so right now, our capacity is really around acute assessment. Again, we do have, at some point, because our patients, all of my patients on our inpatient unit, we have 16 beds dedicated to assessing patients with mental health types of illnesses, including the Alzheimer. So at some points, it's very hard to place patients. You know, we work really hard with CCAC. We bend the rules over the years. We do bend the rules a little. When I was talking about pushing out those boundaries to try and meet needs, I would say that we bend the rules because some of the rules say they can't occupy 2 beds at one time. So what we do, because and that's a funding situation, so what we do is we give them a leave of absence with some transition and try to make a soft transition and see if it works without discharging. I think Andy's program is the new program that's coming up, might be able to be an answer, although it's not called respite, but they would provide some overnight relief for the caregivers. So that might be filling that gap that you're identifying.
It's not enough.
And
If you're looking after, like I looked after my husband 7 days a week, 24 hours a day, one night is wonderful, but there comes a point where you need more than 1 day. And I was in a wonderful facility in Collingwood. Well, I was able to drive him and pick him up, whatever. There's lots of elderly people that are looking after loved ones that would not maybe be able to do that. And I think we need to get really proactive here in Grey-Bruce. Well, look at the numbers you just showed us. It doesn't make any sense that we are not pursuing this. And I know exactly what they're going through, and it's not going to get easier. It would be nice for Sandy to have a week off, maybe, and know that her husband is really well cared for. But the way our system is operating here in Grey-Bruce, it'll never happen.
I would like to say never, because I think what Michael is saying, that resources are being shifted from acute care to community. So I think programs are evolving. Prior to this, we wouldn't have had a behavioral support system that would outreach into the community, at least not for geriatric patients. So that's a new service that we never had. We're really hopeful that that will make positive impact. And so I would say that as gaps are identified, just like you're doing, and then resources get shifted, as new resources come in, I think gaps would be prioritized and dealt with. So
I'd just like to make one more comment. I talked to the mayor of our municipality about the situation, and he told me, and I also talked to the Lynns, we've had some great conversations about this, that it's up to the county administration, plus the administrator in various nursing homes, to decide whether they will open up a bed. And the Lynns people told me that they have tried to work with Grey-Bruce and persuade some of the administrators of the nursing homes to open up a bed for respite. And so far, we've only gotten 2. So if Lynns funds this, you must have a little bit more authority to say, in Grey-Bruce, we do need a couple more beds. And somebody has to step up to the plate and offer a bed.
So, very good questions, and I'm glad to hear that you follow up with the Lynns, because that was going to be my next offer, is that we could follow. I'll take your name tonight. I'm not sure if you've been speaking to Julie Gerard at our office.
Yes, I have.
So Julie is our long-term care home expert and has worked in that sector for a lot of years. I'll talk to you after and just make sure if there's anything else that we can do in terms of follow-up to address your concerns. I think both Elaine and Leah are saying the services that are there, and you're saying, why not some more for Grey-Bruce?
Exactly. Well, I guess my point is, if they can do it in Simcoe County, like, why can't we do it here?
I will tell you that we've been working very closely, CCAC, Mental Health, Grey-Bruce Health Services, working really closely at looking at the long-term care facilities in both Grey-Bruce and trying to facilitate through education of their staff and through trying different ways of trialing patients to actually increase the uptake of patients with behavioral issues into long-term care. Because currently a lot of them are staying put on the psychogeriatric floor. So just in the last 2 years, we've managed to, and then using the new ADP program, we have somebody that's in the new ADP program that's been a resident of our psychogeriatric floor for 6 years. And finally, this man is now able to go out 1 day a week, and we're hoping that will help us to ease him into a long-term care facility. So things are happening. I absolutely hear you and have sympathy for what you've gone through. Unfortunately, somebody has to be a pioneer sometimes. So I appreciate what you're saying, and we have been working together to try and make things better.
Thank you. Other questions?
Just a comment that a lot of the services talked about tonight were for elder care or geriatric care, which is the majority of our population. But I just hope the LHINs will remember there is a great population as well of young people in the area who also need mental health care too. So things like eating disorders, which we see a bit of through public health, but there are still needs for people who are not in those geriatric stages of life too. So I hope that stays on the radar screen at the LHINs level, even though it's not the majority of the population.
Yes, for sure. And a lot of our focus at the LHIN is at the one end of the continuum with real seniors, but we don't lose sight of the others in our population that need food care, including our youth with mental health and addiction issues. So certainly it's there. Other questions or comments? Yes.
Question about the geriatric cooperative. Who, what, and where?
Okay.
Well, I'm the chair of the geriatric cooperative, and Debbie Barker is the co-chair. And it's made up of, when it was formed, when we received the money for this new program, we sent out an invitation to everyone that we could think of, every agency within Grey-Bruce that would touch an elder. And so we invited them to join the cooperative and come together to help provide the service. So that is every agency you saw on the list, plus a whole bunch more that you didn't. And we meet once a month, and we're really guided. There's 4 BSS programs across the Southwest Lit. We are the northern contingency, and by and large we try to standardize across. So every one of these groupings would have their own cooperative, and we're guided by the advisory committee for by Julie Gerard for the behavioral support system. So we meet once a month, we meet for 2 hours, and we basically try to look at education strategy, our referral patterns, those kind of system gaps. Right now we're addressing our gaps, and our next month we met this morning and set the agenda for the next meeting, and that's to look at the gaps and systemically and how we could try to go about between all of our organizations.
Do you report publicly?
I'm sorry?
Do you report publicly?
Our minutes go back to the advisory committee at the LHINs, and we have a plan, because we're just newly organizing ourselves. We have a plan to invite public as a representative to a consumer to the group. We haven't got there yet. That was a decision made by the group that we're not really at that stage yet, and so we will be doing that. So there will be representation from the public.
I don't think that quite answered my question.
Okay, I'm sorry.
Yeah, my question was, do you report publicly? Does the public have access to what you are doing and with whom and where, and who, where the money is being spent and so on? These are public accountability.
Well, we have an agreement with our funders, so we do have a number of metrics that we have to meet, and funding would be part of that. So we do have to report our spending on a quarterly basis back and be accountable to our funders.
To the LHIN.
To the LHINs.
So there's an accountability agreement for those organizations that are receiving funding through BSO, Behavioral Supports Ontario, back to the LHIN, just like we would for any other funding that we flow to an organization.
And then from the Lynn, is that accessible public?
Yes.
Thank you.
Yes.
I just want to say it would be very remiss if I didn't say what a wonderful program homeless community support is. It just made my life so much easier, thanks to Andy and the staff at the Wyerton Day Away. It's just amazing. And CCAC just supported me 110%. So I just have to say how thankful I am for those two organizations.
Well, thank you. And maybe we'll end it there because that's a great way to finish the evening. And we are. We're very, very lucky as our staff and board travel around the Southwest Lynn. Dedicated individuals like all of our speakers tonight and our sixth speaker tonight with Elaine. We are very lucky. So thank you very much for being a very engaged audience. Great questions. Good dialogue at the end. This is what we want from these public engagement sections. Thank you for taking time out of your busy schedules, time away from your families to come tonight. Thank you to Michael and Patty for giving us the caregiver experience. So please just have a round of applause for our speakers. Remember to fill out your feedback form, and again, thank you for coming and have a safe drive home.